Welcome, friends. What an exciting worldwide IWMF Zoom call we have here today. To all of our international affiliates across the globe, bienvenidos, welcome, swagut, and bruchim habayim mikol halev. I am Lisa Wise, and throughout the 12 years that I've lived with WM, the IWMF has been more than just an amazing community. We are WM family. As a board trustee, I'm honored to help coordinate support groups worldwide and to be a support group co-leader here in Philadelphia. We want to thank you for being a part of today's important program. It feels really good to come together. I'm going to take a second here and ask everybody, if you're not muted, to please be sure you are muted, mute yourself. And we're also going to have some help on the back end to have you muted as well. Well, good news. We have something to celebrate, everybody. The IWMF has broken a record today with over 1,050 Zoom registrants from 29 different countries across the globe. It is absolutely no surprise that the esteemed, extraordinary, beloved Dr. Jorge Castillo is the one to amass the most Zoom meeting attendees in IWMF history. Dr. Castillo, all I can say is felicidades. Before Dr. Castillo begins his presentation, we have some hot off the press news to share. The IWMF asked Dr. Castillo and Dr. Shana Sorocek to co-author a detailed booklet educating oncologists on how to diagnose and treat WM patients. The result is this amazing booklet, and it is a WM physician's guide titled Talking with Your WM Patients. I want you to check out the link in the chat below. This booklet was mailed to over 16,000 oncologists. And yesterday, there was an email blast, and it was sent to over 11,000 US hematologist oncologists. So please print one out and consider sharing it with your PCPs and your oncologists so you can help us spread the word and get everyone educated about WM. Again, the link's in the chat, and this is going to be shared widely. So this isn't the last you've heard of this amazing booklet. And we're so grateful to Dr. Castillo and Dr. Sorocek. Before we begin, I have a few quick logistics to cover. Dr. Castillo is going to present for 45 minutes, after which we will have 15 minutes of Q&A. Thank you to my amazing partner in WM Crime, Michelle Postic, IWMF Manager of Information and Support, for her work behind the scenes on today's call. And helping Shelley are our inspiring volunteer leaders. We've got Steve Pine from Texas and Ron Turnaway from Canada. And I want to thank you so very much, guys, for helping out. Now, because of the sheer volume, everybody is muted today, and we apologize in advance that we might not be able to get to all of your questions. There will be more opportunities in the future, we promise. But if you need to move around or stretch your back or take a bio break, please take good care of yourself. Just turn your camera off so you don't distract others. Remember that this presentation is being recorded and the link will be shared. And a little note that a survey is going to pop up in the chat at the end of the presentation. We would love for you to give us your feedback so we can continue to improve all the programs that we offer. So remember to fill out that survey. Now, a word of thanks to our sponsor. The IWMF offers a worldwide thank you to Cellectar Biosciences for generously supporting today's program. Now for our feature presentation. Today, Dr. Jorge Castillo, Clinical Director of the Bing Center for WM at the Dana-Farber Cancer Institute, will be speaking about treatment, trials, and hope for all stages of disease. This important topic seems fitting since, knowing Dr. Castillo over the past decade, I can truly say that I have never had a conversation with him that was not infused with the theme of hope. With kindness, compassion, clarity, and cautious optimism, Dr. Castillo delivers hope every single day. Dr. Castillo was born in the northern coast of Peru. He received his medical degree in Mexico City and completed his hem-onc training at Brown University. After 5 years as an assistant professor of medicine at Brown, Dr. Castillo was appointed at Harvard Medical School. And his clinical practice and research institutes at the Dana-Farber Cancer Institute focus on us, WM patients, where he's the principal investigator in a series of clinical trials evaluating highly effective non-chemotherapeutic approaches. Here on planet Waldenstrom, he needs no introduction. His rockstar international reputation, peerless expertise, and heartfelt care are legendary, and they lead all of us to ask, how does he answer so many emails so quickly and so very, very nicely? It's my distinct privilege and sheer joy to extend my warmest welcome and heartfelt thanks to the incomparable Dr. Castillo for being here and teaching us today. We have 550 people so far on this call. I want to ask every single one of you to please join me across the globe from your kitchen tables, your home offices, and your living room couches. Warmly welcome with me, Dr. Jorge Castillo. Take it away, Doc.
Wow, that was a lengthy introduction, Lisa, a little unnecessary from my perspective. Thank you very much. Yeah, I mean, I think one of the main explanations of why I can answer these emails so quickly is because I have a really good Wi-Fi. I'm going to start doing some advertisement for, cellular phone companies. I have a great wife too. I mean, she understands my goals, and I think that's great. Even my kids, and I was like, I'm going to call, and like they know exactly they need to be quiet. They know exactly what to do. So today we're going to be talking about treatments and trials and hope for all stages of the disease. And I want to start by, what is a stage? When we think about, and I have some slides, so it's not just me, my face all the time. So when we think about, other lymphomas, other cancers, we think about stage 1, stage 2, and if stage 1 is very localized, and stage 4 is much more. And with Waldenstrom's, it's a little bit different because it's a whole body disease right from the start. It's in our bone marrow, so it's very rare to have a stage 1 Waldenstrom's. I would say I have not seen one in my last 10 years of a career, but I know they do exist somewhere. So there's no really stage as per se as we do it in other conditions. But I'm looking at stage in a different way for Waldenstrom's, and you will see that in my presentation. So let's share my screen. And I'm hoping that all you can see my screen currently. So this is my my title officially. I'm the clinical director for the Waldenstrom's program at the Dana-Farber Cancer Institute. I'm an associate professor of medicine at Harvard Medical School. The Dana-Farber Bing Center, we are 2 clinicians and a nurse practitioner taking care of patients with Waldenstrom's, as well as IgM related conditions. We see probably about 2,000 visits per year. About those 2,000 visits, 400 are new patients to our practice. So we're fortunate that patients find value in what we can offer. So to begin, I want to just start talking about the stage. So I think patients are diagnosed and some of them have no symptoms. So I would call that an asymptomatic stage. I mean, not everybody will be in this stage. I mean, on the other hand, everybody will be on this stage at some point, right? Some patients develop Waldenstrom's, and before they become symptomatic, they are asymptomatic. So even they might have been or not diagnosed, they actually are in an asymptomatic stage for a number of years in most cases. Then we will talk about the symptomatic stage, in which there is a frontline treatment, and a relapse disease stage. So I think that's the way I'm going to look at this from the Waldenstrom's perspective at different stages. So for those patients, which is in my clinic about 1 in 3 patients who get diagnosed with Waldenstrom's, but they have no symptoms or have minimal symptoms of the disease, we call that an asymptomatic stage. Some people call it smoldering disease, inactive Waldenstrom's. It's a Waldenstrom's that does not need to be treated just yet. Now, why do we not need to treat patients, at the moment of diagnosis? It's a hard sell sometimes, right? Because we're talking about a blood cancer. We're talking about a blood cancer that has no cure, but we're not going to do anything about that. We're just going to monitor it for the time being, watch and worry, which many people call it. But there's a number of reasons why we don't have to treat everybody at the time of diagnosis. Number one, we don't cure Waldenstrom's. As of today, we don't have a cure yet. There are people all over the world supported by the foundation working on trying to find a cure for this disease. So I think at some point we'll see that. But as of today, we don't have a cure. And that's one of the main reasons we want to treat cancer, right? Because we can cure it. The other important reason to treat cancer is because we can prolong the patient's survival. But in Waldenstrom's, specifically asymptomatic patients with Waldenstrom's, they have a normal life expectancy, as we will see in a second. So we are unlikely to prolong survival in patients who are asymptomatic, even if we treat them. Now, our treatments are fantastic. We'll see that in a second. But our treatments do have side effects and do promote resistance. If you expose a cancer to a treatment and you don't cure it, the second time you want to try that same treatment, it's not going to work as well as it did in the first time. And that's why we need more and more treatments down the road, providing different ways of targeting this disease. And that's why research never ends. We did a study in which we put 440 patients, right on the right side, 440 patients who were asymptomatic at the time of diagnosis. And we followed those patients over time to see how long it took for these patients to actually need therapy. Within the first 2 years, 30% of those patients needed to be treated. And if we, so that's about 15% per year. But then they kind of flattened out to about 7% per year. And about the 10-year mark, we have an 80% of patients needing therapy, which means that from each and every 5 patients who are diagnosed asymptomatic, 1 of those patients are not going to need treatment for longer than 10 years. So I think that's another good reason not to treat our patients who are asymptomatic, mainly if they have these, good profile. Now, how do we know, the profile of the patients? We do have a patient risk calculator, and this is available online at the awmrisk.com, which is asymptomatic Waldenstrom's risk. And basically what happens here, this is a study that we did in conjunction with other groups, including the Mayo Clinic and some European colleagues. If we know the bone marrow infiltration in the bone marrow biopsy as a percentage, the IgM level as milligrams per deciliter, and I want to make clear that you understand the units, because outside of the United States, the units might be a little bit different. Beta-2 microglobulin levels in milligrams per liter, and albumin levels in grams per deciliter. So all these 4 values need to be taken around the same time. It's not fair to use the IgM level from 2020 and the bone marrow infiltration from 2015. That's not the way it works. Around all the values around the same time. And in this case, I put a 40% involvement with a 3500 IgM, 2.5 beta-2, and a 4 level of albumin. You click here on calculate risk score, and it will give you the risk score of the patient who is asymptomatic, meaning when the patient is likely to need therapy. Now, for this case, in a medium category, the median time to progression is 4.8 years, which means that if we take 100 patients like this, half of these patients are going to need treatment within 4.8 years, and the other half is going to go beyond 4.8 years to need therapy. So I want you to understand what median means when I'm talking about these statistics. Now, as you can see, patients can be divided in 3 different groups, right? The low risk, in whom the median is 9 years, the intermediate risk, in which the median is about 5 years, and the high risk, in which the median to be treated is about 2 years. Now, this does not tell me who I need to treat. I want you to understand that it's not because you're a high risk you need to be treated. That's not what I'm saying. I'm saying you need to be monitored maybe more closely. So what I do is I tend to follow patients every 6 to 12 months if they're in the low risk, every 4 to 6 months if they're in the intermediate risk, and maybe every 3 to 4 months or 2 to 3 months if they're in the high risk. So closer follow-up, but not necessarily an indication to treat. These findings were kind of validated in a study by the Mayo Clinic, just published fairly recently. And again, very similar to our data at the 10-year mark, about 80% of patients needed to be treated, which means it's about 20% of patients who do not need treatment beyond, for longer than 10 years when they are asymptomatic at diagnosis. In this study, they actually saw that patients with anemia tend to have a faster progression, and patients with higher levels of beta-2, which is similar to our study, they needed treatment a little bit sooner. And again, what they did, which is very interesting, is this is the survival curve of the patients who are asymptomatic at diagnosis over time. They have 25 years of follow-up. compared to the expected survival of the normal population. And you can see how the curves are almost indistinguishable. Statistically speaking, these curves are equivalent. Therefore, the survival of patients who are asymptomatic matches the survival of an individual of the same age and sex and race in this country. And therefore, one more reason not to pursue therapy if it's not necessary. Having said all that, at some point, most of our patients will develop symptoms of the disease. And there are so many different symptoms that is what actually keeps my life interesting from the clinical perspective. Patients can have different clinical features and different presentations. And I think that's actually, keeps it very, very interesting for me. So patients, more likely than not, when they become symptomatic, they develop anemia. The hemoglobin gets lower, patients develop fatigue and shortness of breath and tiredness. And that's actually still the most common reason to treat patients with Waldenstrom's. This anemia could be because of bone marrow replacement. There's no space in the marrow to produce the red cells necessary. There might be some iron deficiency here on the bottom, or even there could be some red cell destruction as well. A classic presentation of Waldenstrom's as well is hyperviscosity when the IgM levels are very, very high. I'm talking about 4, 5, 6, 7,000. And these are patients present with numbness, with nosebleeds and headaches and blurred vision. And if you look into the back of their eyes and the retinas, they see some microbleeds sometimes or some other changes in those vessels. And those patients need to be treated immediately. They need to probably have some filtration of the blood. We call it plasmapheresis, and then start therapy after that. Another classic presentation that is very challenging to manage is neuropathy. This is patients who have numbness in the feet. Mainly, it's bilateral. Both sides are affected almost at the same level. It's a numbness issue much more than pain or weakness, and that prolongs, progresses very slowly over matters of months to years in most cases. Other clinical presentations have the cryoglobulins and cold agglutinins. These are situations in which the IgM actually clumps under being in patients who are exposed to cold temperatures. And with cryoglobulins, we see changes in the hands and changes in color in the hands and feet. It becomes red and purplish. With cold agglutinins, actually, there's red cell destruction. The clumping of the red cells causes those red cells to destroy, and patients become anemic very rapidly. Some people can have amyloidosis because of Waldenstrom's. And we have the whole slew of extramedullary disease. Classically, the lymph nodes and enlargement of the spleen, but we can also see renal disease, which is very common in myeloma, but much less so in Waldenstrom's. We can see some pleural effusions. We can see some big Neal syndrome, which is the affectation, the involvement of the brain by Waldenstrom's, and even some lytic lesions, which is very common again in patients with myeloma, but much less so in patients with Waldenstrom's. But again, all these clinical presentations can be possible. And the most important thing to diagnose Waldenstrom's is to suspect it in the first place. So then we get to a point in which patients need to be treated. And because these patients are never treated before, these are treatment naive patients. That's the treatment naive stage. We call it primary therapy. We call it frontline treatments or treatment naive stage. We have a number of reasons to treat, and I mentioned these earlier. Anemia, constitutional symptoms. Patients can have weight loss and fatigue and tiredness and fevers and night sweats. The viscosity we talked about, the neuropathy, the extramedullary disease, cryoglobulins, cold agglutinins, and amyloidosis. These are all reasons to treat, but the key here is symptomatic. Patients could be mildly anemic and not be symptomatic from it. Patients can have detectable cryoglobulins, but not be symptomatic from it. Patients can have a little bit of neuropathy, but really the neuropathy might not affect the patient's activities of daily living, might not be progressing. So, the fact that you have a symptom doesn't mean that you need to be treated. It has to be symptomatic, progressing, affecting the patient's quality of life. That's the moment in which therapy should be considered. Now, these are the guidelines that we use in the United States to treat patients with Waldenstrom's. And as you can see here, there are preferred regimens and then other recommended regimens. In the preferred regimens for the primary therapy or the frontline therapy of patients with Waldenstrom's, we have chemotherapy, bendamustine and rituximab, which is one of the most effective regimens we have. We have bortezomib, dexamethasone rituximab, or BDR. And we do have BTK inhibitors as well, ibrutinib and zanubrutinib, ibrutinib with or without rituximab. As you can see here, these two are the only ones with category 1. Category 1 means that these treatments are supported by the presence of randomized studies. So we do have plenty of studies with bendamustine and BDR, but those are single-arm prospective studies and not precisely a large randomized study, which ibrutinib and rituximab and zanubrutinib do have. There are other treatment options as well down here, other chemotherapies like cyclophosphamide and other proteasome inhibitors like carfilzomib and ixazomib. So just to give you an idea of what we're talking about in terms of efficacy, these are the different regimens that we use, right? Cyclophosphamide, bendamustine, bortezomib, carfilzomib, ixazomib. These are all available in the United States. Outside of the United States, the options are a little more limited. Cyclophosphamide and bendamustine are almost universally available, even bortezomib. Carfilzomib and ixazomib, not so much. And in other areas with lower incomes, cyclophosphamide is pretty much all they have, and bortezomib and bendamustine becomes prohibitive in terms of price. So we need to be mindful of all these, limitations. But what I can see here, what we can see is the response rates, meaning, how often, there's an IgM decrease by at least 25%, is very high. Pretty much everybody develops these benefits from these treatments. The major responses are when the IgM drops at least by half. And again, very high, proportion of these patients as well. And progression-free survivals, meaning how long it takes for these patients for the disease to progress. I want to point out that this is a median as well, which means it's not everybody progresses at 69 months. For example, for bendamustine, it's half of the patients progress within 69 months, and the other half went beyond 69 months before they progressed. And again, the progression are also very substantial, ranging anywhere between 3 and 6 years. Maintenance, we were using that for a while because there was benefit in other lymphomas, and we were doing it in Waldenstrom's as well, and we thought there was benefit at that moment. The Germans did a study that has not yet been published, but if you get a partial response, at least a 50% decrease in IgM after bendamustine or rituximab, they separated the groups in two in a random manner. On one hand, patients were observed, and the other hand, patients got rituximab every 2 months for 2 years, and really did not see a benefit in terms of progression-free survival or overall survival in these patients. So for that reason, if patients now are being exposed to chemotherapy and rituximab and they get a good response, we are actually using less and less maintenance. But again, this is a preliminary report. We are still waiting for the final report to be published, hopefully this year. And then we have the other groups of patients called BTK inhibitors. And again, I would say these are probably the most effective regimens that we have in Waldenstrom's, mainly because everything that has mentioned so far, bendamustine and bortezomib, are in combination with rituximab. These are combination regimens. BTK inhibitors like ibrutinib or zanubrutinib can be given alone. And even alone, they are very, very effective. You can see here the overall response rates, anywhere between 90 and 100%. The major response rates between 70 and 80%, and progression-free survivals also measured in several years. So a lot of times I get the question is, so what is better? Is chemotherapy better, or is a BTK inhibitor better? To treat patients with Waldenstrom's. And I don't think there's a study currently that had been done that can show that one of them is actually superior to the other. That doesn't exist. So we have to go by the individual studies to kind of make sense of all this. I would say both regimens are almost equally effective. The difference is how is it given? Chemotherapy is almost given intravenously for about 6 months. BTK inhibitors are pills you have to take on a daily basis, but those pills need to be taken indefinitely. So, I do get to see patients who prefer, taking pills, even though it's an indefinite duration treatment. I do have patients who prefer to get treated intravenously, and because there's a finite duration treatment, they all have their own problems and their own side effects. And actually, that is something that you need to discuss with your doctors if any of these treatments are being evaluated, so you can make an educated decision. So these are the data supporting ibrutinib monotherapy in the frontline setting. I mean, the response rate was almost 100%, with a major response rate of 87%, and a very good response. This is a 90% decrease on the IgM. That's a deep response of about 30%. Again, there is a group of patients who will have mutations in a gene called CXCR4. That's about 1 in 3 of patients with Waldenstrom's. And if you have a CXCR4 mutation, the responses tend to be just a little lower rate of responses, and also the progression-free survival tend to be a little bit more, a little less, durable in patients who have these mutations in CXCR4. Now, ibrutinib was approved by the FDA in 2015 to treat patients with Waldenstrom's, and it was the first medication ever approved to treat Waldenstrom's by the FDA. There's a second study in which ibrutinib and rituximab were combined, and this was compared against rituximab alone. And again, we can see how the progression-free survival of the combination is definitely much superior than rituximab alone. And regardless of which mutation profile you have, if you had MYD88 only or MYD88 with CXCR4 or none of the two, the combination almost always was associated with a higher rate of responses. CXR4 mutations had a lower response to the combination compared to patients without CXR4 mutations. Now, this study really tells me that ibrutinib improves rituximab, but it doesn't really tell me if rituximab improves ibrutinib. For that, we have had a third group of people that actually took ibrutinib alone. We have ibrutinib rituximab, ibrutinib, and rituximab, but that group of ibrutinib alone does not exist. The study was not done in that manner. So it's very difficult at this time to assess what the benefit of adding rituximab to ibrutinib is. And I don't think that will be demonstrated in a clinical trial. Now, based on the results of this study, the FDA approved the combination of ibrutinib rituximab in 2018. As we can see here, based on the mutational profile, the red curve are the patient with MYD88 only disease. The green curve is the patient with MYD88 and CXCR4. There's a bit of a separation there, but it's not such a massive difference, but there's a little bit of a separation as well. In any case, these treatment options are amazingly effective for these patients too. And more recently, we have a medication called zanubrutinib. They went on a clinical trial compared against ibrutinib, about 100 patients per arm. And the idea was to show that zanubrutinib had a higher rate of very good response than ibrutinib. At the time that this paper was published in 2020, there was a bit of a difference, 28% versus 19%, but this difference was not large enough to be called significant. And for that reason, at that moment, in terms of efficacy, the study did not meet its endpoint. And as you can see here, at the time of the publication, the progression-free survival was pretty much interchangeable between the two groups. Where we did see a difference was in the side effect profile. The risk of AFib, which is one of the major concerns when treating patients with BTK inhibitors, was a little higher with ibrutinib at about 15% at 18 months, compared to about 3% at 18 months with zanubrutinib, so lower rate of AFib. There was a little bit more neutropenia, however, with zanubrutinib at 18 months, about 30% versus 15% with ibrutinib. Now, this study has been updated, and sorry for this busy slide. This study was updated recently at ASCO and also presented at the Waldenstrom's workshop in Madrid. And we can see how the very good response has increased in both groups. At 44 months, it's almost 4 years now, 36% with zanubrutinib, 25% for ibrutinib. Again, shows a superiority for zanubrutinib, but the study was not designed to look at this specific point. And you can start seeing a little bit of a separation between the curves of progression-free survival, favoring zanubrutinib just a touch. But again, this difference was not in the statistical significance range yet, but you can see a little bit of a separation there. And when we look at the side effects, there's definitely lower rates of AFib, lower rates of hypertension, lower rates of bleeding, and lower rates of infection with zanubrutinib, and the risk of neutropenia kind of leveled off a little bit between the two groups. Now, I want to be very clear here. I'm not saying that zanubrutinib does not have side effects. It does. It's just the rates of side effects are lower than ibrutinib. We see still patients developing hypertension and atrial fibrillation and bleeding with zanubrutinib as well. And obviously, this is a conversation to be had with your doctors locally to understand which are better treatment options for you. In CXCR4, we see how zanubrutinib had a higher rate of VGPR, about 21% compared to ibrutinib. This is lower than patients without CXCR4 mutations, but zanubrutinib seems to do better, a little bit better than ibrutinib in patients with CXCR4 mutations. And again, the progression-free survival on these patients is a little bit higher, between 73% versus almost 50%. Again, not significant difference yet, based on the number of patients, but we can see a little bit of a separation there as well. So bottom line, I think we have great options for the frontline treatments. We have chemoimmunotherapy, we have BTK inhibitors, and obviously you can get either or, right? What I tell my patients is, I don't think you are choosing what to use. It's not like you're choosing chemotherapy over BTK inhibitors or BTK inhibitors over chemotherapy. I think what you're choosing is just what to use first, right? Because if a patient is going to have chemoimmunotherapy first and the disease will come back later on, then BTK inhibitors will be there to help. If a patient gets BTK inhibitors as a first treatment and the disease progresses well on a BTK inhibitor, then you have chemotherapy there to help in the relapse setting. So again, it's not what to use, it's what to use first. And I think that's a good understanding of how this disease moves around. Now, when the patient's disease come back, again, if you got chemotherapy, you can use BTK inhibitors. You got BTK inhibitors, you can get chemotherapy. A very important message here is we need to use the same criteria that we used in the first place to treat the second time. It's very common. Patients come to see me and I said, yeah, my IgM was 4,000 and I got treated, and it went down to 1,000 with my treatments, and now my IgM is 3,000 and I feel well, but my doctor wants to treat me. And the patients are not precisely symptomatic, even though the disease is actually progressing. So the IgM going up is pretty much the hallmark of disease progression, but that doesn't mean that the patient need to be treated. There have been a few studies published on this, and from the moment in which patients meet this disease progression criteria to the moment in which they actually need therapy, there's actually a gap that could be years sometimes between the two spots. So just IgM alone increasing is not a real indication to treat, and we should still wait for the symptoms to appear. Obviously, you don't want the patients to be too symptomatic, but at least you want to make sure the patient does have some symptoms that are affecting the patient's activities of the daily living before proceeding with therapy, as we do for the frontline setting as well. And these are, again, the options for patients. There are multiple treatment options. We can, again, use the same options that we used previously. We can use bortezomib, we can use cyclophosphamide, bendamustine. If they were not used before, we can use those options currently. Again, we have venetoclax here, which is new. We'll talk about that in a second. Acalabrutinib, which we have not talked about just yet. And many other options, including transplant. And I'll talk about transplant just a little bit later. So Dr. Trion conducted the seminal study looking at ibrutinib in patients with Waldenstrom's. This is actually the study that prompted the approval of ibrutinib by the FDA in 2015. 63 patients were exposed to ibrutinib monotherapy, which means it's only as a treatment alone without any other additives. And the responses were amazing, specifically for patients with the MYD88 mutations only. Or response rate 100%. Almost all of them were major responses, 50% decrease in the IgM, and almost half of these patients had a 90% decrease in their IgMs. When you have CXCR4 mutations, the responses are a bit lower, but patients still benefit from these treatments. And patients without MYD88 mutations, they are less likely to benefit from these ibrutinib. Progression-free survivals, again, much better for MYD88 only, 75% free of progression at 5 years. With CXCR4, it's about 50% at 4 years, which is lower. And for patients without MYD88 mutations, it's about 50% at 24 months, which is definitely much shorter. Acalabrutinib is another BTK inhibitor that is available in the United States to use. The NCCN endorses the use, but it's not FDA approved for Waldenstrom's formally. I think there was a question about this, and this is just the company decides what they want to apply for, and the company decided not to apply for FDA approval for Waldenstrom's. And again, this is a single arm. There's no comparator, so it's hard to say if it's superior or not to ibrutinib or zanubrutinib at this time. But the responses are very high up there, over 90%, major responses over 80%. And progression-free survival, this was recently updated at the European Hematology meeting in this past July, with a median progression-free survival approximating 6 years, between 5 and 6 years for patients with relapse disease. But for the small group of patients who were treatment naive, really a much better progression-free survival. And again, this is something that we see very often with many different treatments. They tend to work better in patients who have not been treated compared to patients who have been previously treated. And again, this is a treatment option for patients with Waldenstrom's. It's a twice-a-day type of medication. The risk of AFib may be a bit lower than ibrutinib, maybe a little higher than zanubrutinib, but again, there's no comparisons head-to-head. Venetoclax is another type of medication. It's a BCL2 inhibitor. It's a pill as well. And in this study, we actually treated patients with previously treated disease, and half of the patients were actually previously exposed to a BTK inhibitor, which was very interesting. So we could see the responses, about 80%, almost 20% very good responses. Most of the responses were major responses. So we have a very good treatment option here. Now, the issue here is that we decided to treat patients for 2 years. We wanted to investigate the possibility of giving patients non-chemo treatments with a finite duration treatment. As you can see here, the curve of free of survival was going very well, around 80% until the 2-year mark. And this is when all the patients stopped therapy. And this is when we started seeing some of the progressions, most of them happen in the first year of therapy. So I think this begs for the use of venetoclax because I think it really works. We still need to understand the duration of the treatments, and maybe some patients will benefit for longer than 2-year treatments. Maybe it has to do with the depth of the response before, stopping therapy. So there's a lot of research still to be done with these agents, but we do think that is an agent of value, mainly because patients with CXCR4 mutations did not seem to progress any faster in patients with this therapy. So the NCCN endorsed venetoclax for the use of patients with Waldenström previously treated, but it's not FDA approved for that condition specifically. So as you have seen, we have multiple treatment options, and all of them are very safe, very effective. But again, we need clinical trials. We need clinical trials because we have not cured everybody, or anybody. We have clinical trials. We need clinical trials because we need to provide higher efficacy rates, longer durability, less toxicity. So I think all those reasons really, give us the opportunity to develop these trials in order to, benefit our patients the most. So I'm going to talk about some selected clinical trials. Not all the clinical trials are here. So if you don't see your favorite clinical trial or the clinical trial you're participating here in, I apologize in advance. But these are the ones that I put together. The first one that I want to mention is the study that we were running at Dana-Farber, combining ibrutinib and venetoclax. I mean, we in the laboratory led by Stephen Trion, we saw that there was actually synergism between these two agents in killing Waldenström cells more effectively. So we decided to run this study. This combination has been previously treated in other malignancies like chronic lymphocytic leukemia and mantle cell lymphoma with amazing responses. So ibrutinib for a cycle, and then cycle 2 was the ibrutinib, and then the increased dose of venetoclax over a month, and then for 22 more months, both agents on full dose. And the idea was to stop therapy at the 2-year mark, as we did with the prior study. This is the data that I presented in December. This is fresh data. The response rate was 100%, with a major response of 93%. In a very good response of 40%. That was the outcome that we were looking for. We were looking for a very good partial response, between 40 and 45%. So we did. So this study actually showed that this combination was as effective as we thought it was going to be. Patients with CXCR4 mutations had a bit lower VGPR rates compared to the patients without CXCR4 mutations, but the overall response rates and the major responses were very similar to each other, to the point that these differences are not called significant. Patients, about 12 months of follow-up, 92% of patients had not yet progressed. This is about a year mark, which is an interesting finding and very encouraging as well. The problem that we had with these treatments was the emergence of ventricular arrhythmias. So the study was designed to enroll 50 patients, and we enrolled 45 patients, and then we stopped enrollment earlier because of these arrhythmias. So 2 of these patients actually died from these arrhythmias. These were patients who had other cardiac risks, and some of them had other arrhythmias, some of them had other coronary artery disease, and some other conditions that increases the risk of having these problems. But given the fact that, about 4 patients, 2 of them, fatal, but the other 2 non-fatal, amounted to about 4, it's about 10% of the patients having these side effects, we decided to stop the study, and everybody stopped therapy at the end of March of 2022. The side effects otherwise were very compatible to what we had seen previously. And obviously trying to understand why, these happened, these arrhythmias happened, we still don't have a good understanding. We have not seen this combination doing this previously in other conditions, in other trials. The medications do interact with each other, but not to the point of causing something like this. Could it be possible that there is something about Waldenström's that makes this combination, less safe? Is it possible that these medications kind of interacted with each other in addition to the IgM paraprotein? Is it possible these patients had other risk factors beyond what we could see that made them have even a higher risk? Or it could just be a random finding, just one of those samples in which we see this and it would not have happened again. So it's very difficult to know. But I think the bottom line message here is that the combination of BCL2 and BTK inhibitor is very powerful, and I think needs to be evaluated further, hopefully with safer combinations and with a much closer follow-up to make sure that we are on top of these potential problems down the road. Again, I mentioned earlier that there's not a lot of studies comparing chemotherapy versus non-chemotherapy. And this is one of the studies that do that. And I think this is interesting. This is the Rainbow study. Is comparing ibrutinib rituximab versus dexamethasone, rituximab, and cyclophosphamide. This is, I think, formally the first study that is comparing a BTK inhibitor versus a chemotherapy approach. This is being run in the United Kingdom. It's a randomized phase 2-3, and about 148 participants will randomize 1-to-1, meaning half and half. Half of the patients will be in experimental arm, as you can see down below, and half of the patients will be the comparator arm. And the idea is to look at the response at, within 24 weeks, which is 6 months, and obviously the progression-free survival at 2 years. This is the clinical trial registration on the right. The other study is the VWA study. This is being run in Germany. They're actually combining venetoclax and rituximab, and they're comparing against cyclophosphamide, dexamethasone, and rituximab. So that's another study being run in Europe, comparing a non-chemo treatment with a chemotherapy treatment. This is a phase 2 study. About 80 patients will randomized, and the primary outcome is to see how many patients get into a VGPR or better, within 12 months of therapy. The Canadians are doing an amazing study here, combining actually a triple therapy. This is acalabrutinib, bendamustine, and rituximab. This is called the BROM study. This has been run in 19 centers in Canada. The study will accrue 59 participants. It's all treatment naive. And the idea is to give patients 6 cycles of bendamustine and rituximab, 1 year of acalabrutinib. So this is going to be concurrent. And then a whole year of acalabrutinib, and the acalabrutinib will be stopped. So this is not indefinite duration therapy. So a triplet, chemotherapy combining with BTK inhibitor, and a BTK inhibitor is going to be finite. So very interesting study. At ASH, Dr. Berenstein, who's the main investigator here, presented the initial data on the first 10 patients, of which 8 had attained a VGPR. That's an 80% VGPR rate. So very exciting study. We need to look at, there was some more toxicity in terms of neutropenias and other problems, but I think we need to look into these type of approaches in the future as well to understand how we can deepen responses and hopefully maybe get to a cure. Now, many of you know about the new BTK inhibitors, specifically the non-covalent BTK inhibitors. These are BTK inhibitors that seem to work even when patients stop responding to the older generation BTK inhibitors. And there are a number of them, but the one that I'm going to show here is pirtobrutinib. This is actually data presented by Dr. Leah Palombra from Sloan Kettering at ASH in 2022. Sorry, that's a typo down there. And as you can see here, there's a graph. We call it cascade, the waterfall graph, and you can see these bars going down on the left. So I want to just bring your attention to the dark blue bars. Those are the patients who were progressing on a covalent BTK inhibitor and now are responding to a non-covalent BTK inhibitor. So the response is about 67%, which is actually very encouraging on these type of patients. Again, many of these patients got into VGPR. Between 25 and 30% of these patients got into a VGPR with these new treatments. So very encouraging, very exciting. We have a study planned to start at the Dana-Farber later this year, combining pirtobrutinib as a safer agent. We don't see bleeding. We don't see arrhythmias with this agent in combination with venetoclax for patients, with relapse Waldenström's. My colleague, Dr. Shena Saroshek, is running. She's actually leading the immunotherapy component of clinical trials, and she started with this study with an antibody drug conjugate targeting CD19. So this is kind of a rituximab on steroids, but targeting CD19 instead of CD20. This is called loncastuximab tesirine. This agent is already approved for the treatment of diffuse large B-cell lymphoma, and now we're trying it in Waldenström's. It's a multi-center study, a total of 36 participants. Every participant will have to be exposed to chemotherapy and a BTK inhibitor. So this is actually a true third-line treatment, and 6 cycles, just 6 infusions done, and then look at the overall response rate. When I get at least a 70% response rate. So we have so far a little more than a handful of patients enrolled in this study already. There's another immunotherapy called iopofosine 131 or CLR 131. This is the CLOVER-WhAM study. It's a multi-center study. They're going to enroll about 120 participants, including myeloma and other lymphomas. But also there's a very important group of patients with Waldenström's that will need to be enrolled in this study. About 50 patients is the planned enrollment. There's already some data presented at ASCO last year by Dr. Ayla Wari from the Mayo Clinic in Jacksonville, showing some initial efficacy even in patients without MYD88 mutations. to iopofosine. So this is 4 infusions over a lapse of about 3 or 4 months. Being a radioisotope, patients need to be careful, for several days after the infusion of these therapy. But the FDA provided a breakthrough designation for iopofosine 131 for patients with Waldenström. So very exciting study. And the most recent addition to the clinical trials for patients with Waldenström's is CAR T cells. This is actually Brexucel or brexucaptagene autoleucel, Brexucel. This is an anti-CD19 CAR T cell product that is already approved in the United States for the treatment of mantle cell lymphoma. So this is study Zuma 25. In this study, they're going to be targeting rare B cell malignancies, including Waldenström's. And about 60 patients are being planned to be part of this study. And they are looking at, a VGPR rate or better. And again, this is another true third-line treatment in which patients need to have been exposed to chemotherapy and a BTK inhibitor before becoming part of this study. Just to remind you, refresh your memory, patients need to undergo leukapheresis, take their own T cells out for manufacturing of the new product. And then the patients get lymphodepleting chemotherapy, which at this time is fludarabine and cyclophosphamide. This is given day -5. Then the infusion of the manufactured product will be given on day 0, and patients need to be hospitalized for about 10 to 7 days to manage potential side effects the patients can experience, and then patients could be discharged and then followed. And there's a first disease assessment about 28 days later. So very exciting clinical trial as well, in the realm of immunotherapy. Some quick conclusions, and then I'll be open for questions. I think the observation phase is best for patients who are otherwise asymptomatic. There are many reasons to do this, and we have a number of patients who have been, 20 years, 30 years being observed without the need of therapy. So if you're going to be one of those patients, it's better to be one of those patients that are being treated unnecessarily. Now, the current treatment options, I'm talking about chemotherapy, BTK inhibitors, protein inhibitors, BCL2 antagonists, are very safe, highly effective regimens. But still, we need to develop newer treatments because we don't cure this disease yet. So therefore, we need to develop safer treatments, shorter treatments, more effective treatments that will improve the patient's quality of life, maybe with novel mechanisms of action. And I think this is where targeted agents in combination, newer targets, and immunotherapy are providing a really important advances, will provide important advances in patients with Waldenström. So I think I can finish saying there is hope for all stages of the disease. And with that, I want to thank you for your attention, and I'll be happy to answer any questions you may have.
Dr. Castillo, thank you so much for that incredibly informative and helpful presentation, and saying that there's not a choice between chemo and BTK inhibitors. We're choosing what to use first, I think is just life-changing, because this is a marathon, not a sprint. So it's not always putting up one or the other. It can be and. So we have an enormous amount of interest and an enormous amount of participation with a whole lot of questions. Dr. Castillo, would you like me to tell you about the different types of questions, and you can think about how in the next 10 minutes you want to tackle them, or you want me to go one at a time? I can just give an overview.
Yeah, I think one at a time is fine, and then we can just try to answer those questions the best we can.
Okay, perfect. Because the first question is about the benefits and risks of BTK inhibitor dose reduction. We've been seeing a lot of interest in people have about playing around with the amounts. Would you like to speak to that, please?
Yes. So actually, we published a paper just recently, specifically on this topic. So about 400 patients on ibrutinib in our clinic were analyzed, and about 25% of those patients needed to have a dose reduction because of toxicity. So we don't dose reduce because of efficacy. It's not because the patients are doing great that we decrease the dose. We decrease the dose because patients are having some problems. And again, joint pains, rashes, diarrhea, fatigue, bleeding, there are arrhythmias, there are hypertension. There are many reasons to decrease the dose. From all the patients that we decrease the dose, more likely the risk was higher in women or older than 65. So age older than 65, independently of being woman or not, and being a woman, independent of the age, were both the most common reasons or most common features associated with dose reduction. Most patients were dose reduced to 280, which is the next step. In some patients, actually, we dose reduced to 140, but that was a very small group of patients. Now, I would say about 70% of the patients had an improvement in the in the symptom that prompted the dose reduction in the first place, and over 80% of the patients sustained the responses, so they didn't lose the response, after those reductions. So I think if there is a side effect that is prohibitive, dose reduction is a reasonable approach for most patients with Waldenstrom's.
Thank you so much. Most helpful. Moving to the next category. This is one which is a little tricky, but I'd like to group them all. We're hearing from folks who have different kinds of mutations asking, what about current treatment options for me? Here's the different categories, and you can think about how you want to answer this. So that same question, what treatment options are there for me, was asked by folks with CXCR4 mutations, TP53 mutations, those with wild type WM, and lastly, we have extramedullary disease, folks looking for more treatment options. So I thought I would just kind of group those.
Yeah, makes sense. So I think MYD88 mutations are seen over 90% of patients with Waldenstrom's. The CXCR4 mutations maybe in 30 to 40%. And now TP53 mutations, are seen also maybe about 5 to 10% of patients with Waldenstrom's too, and maybe even more depending on some of the reports that we have seen. So I think that can help us tailor treatment options. And again, I'm just giving my opinion. The MYD88 only group, I think those are the patients that tend to do the best with BTK inhibitors. Those are the outcomes that we tend to see, the best with those groups. The patients with CXCR4 mutations, I think the newer BTK inhibitors tend to be, maybe a good option. Chemotherapy will definitely work very well on those patients, and protein inhibitors as well, and venetoclax too. If you have a TP53 mutation, that sometimes means, depending on which mutation is it, there could be some resistance to chemotherapy. So in those patients, maybe a non-chemotherapeutic agent might be best. Now, I just want to be very clear about this. None of these mutations means that you will not benefit from a treatment. So even patients with CXCR4 mutations benefit from BTK inhibitors, and patients with TP53 mutations, they benefit from chemotherapy. So none of these are, because I have this, I cannot get that treatment. It will give us maybe some preference in terms of what treatment you could use. But at the end of the day, most of patients with Waldenstrom's will be exposed to all those treatments regardless of the mutation status. It just sometimes might affect the order a little bit.
Excellent. Thank you so much, Doctor.
And I forgot about the extramedullary disease.
Extramedullary. I just
yeah, there was something there. So yeah, for extramedullary disease, I mean, pretty much every treatment that works for Waldenstrom's will work for extramedullary disease. Now there's probably some treatments that work a little less effectively for extramedullary disease, and I would say probably those are the protein inhibitors. I mean, I think bortezomib, carfilzomib, ixazomib are amazing treatment options. But maybe for patients with bulky lymphadenopathy or large spleens or some other might not work so well. Having said that, for patients with kidney disease, for example, because of Waldenstrom's, I think those are great options for those patients too. So it has to do a lot with personalization of therapy, and that is sometimes why it's a good idea to see a specialist, at least once, just to get an idea or a sense of what might be, a more reasonable, personalized approach.
Thank you. There's always a lot of interest and concern, understandably, about the potential for transformation to a more aggressive cancer. Could you speak about the rate of developing, let's say, DLBCL between different groups, like patients that were treated with chemo versus treated with BTK inhibitors, or anything else you want to say about those kinds of transformations, which is always in the back of WMers' minds?
Yeah, so transformation to a more aggressive disease almost always is a diffuse large B-cell lymphoma. Which is the most common aggressive lymphoma everywhere. It happens at a very low rate. It happens at a rate of about 1% every 5 years. So it's not a very common issue. And so far, we do not believe there is a specific agent or treatment that increases the risk. So we have seen transformations after Benda-R, we have seen transformations after BDR, we have seen transformations after ibrutinib. I don't think there's one treatment that increases that risk. I think that risk is going to happen, regardless. I think the only scenario in which I think there's maybe a higher risk of transformation is the patients who do not have MYD88 mutations. I think have been at least 2 studies from us and from the Mayo Clinic suggesting that the rate of transformation to an aggressive lymphoma is higher in those patients without MYD88 mutations. But again, it's not a 100% risk, so it's still a low risk, but something to think about.
Okay, excellent. And can you spend a few minutes discussing COVID and the immunocompromised? Time for an update, like specifically whether there are any new treatments or preventative measures or new vaccines on the horizon, given all these new variants?
Yeah, no, that's a great question. So I think at the beginning of the pandemic, COVID did a big number on our patients for a number of reasons. I think on one hand, some patients might have not been vaccinated. On the other hand, even if they were vaccinated, they were not able to mount a good response to the vaccines. That has changed, I would say, at least in the patients that come to see us. And again, that could be a biased observation. But in the patients that come to see us at Dana-Farber, I would say the large majority are vaccinated and vaccinated fully, all the way to the bivalent, the 5th dose of the bivalent, vaccine. And what we have seen in our research, which we are trying to publish, is that even though the start is a little sluggish in terms of antibody production, as patients get more doses, actually that antibody production actually happens. I mean, still patients who are on active therapy might have lower rates of response. And I'm talking about patients who are on active chemotherapy or active rituximab or active ibrutinib or zanubrutinib, that those might have still a lower rate of response. But it's not like they do not respond. We have a lot of patients who are on active BTK inhibitor therapy, and then we have seen the responses from the vaccine perspective. A little less with rituximab, but it's not zero. My message is get vaccinated. If you're not totally opposed to it, obviously your decision is yours, right? If you want to get vaccinated or not, but get vaccinated. We are seeing responses to the vaccine on patients, and the more vaccines you get, the more likely are that you're going to respond. Now, if you get infected by COVID, Paxlovid is an option. There are other options also, like remdesivir and molnupiravir and all these other antivirals. Paxlovid still, by what we believe, seems to be the most effective against the current variants, the Kraken, they call it, so against the current variants. But you don't need to be treated. If your symptoms are very mild, like a common cold, you don't have to run for Paxlovid if your symptoms are mild. If the symptoms are more moderate and you're unable to eat or drink or take care of yourself, then I think that's reasonable to pursue antiviral therapy, because it has its own side effects too. A lot of some diarrhea and some other gastrointestinal problems. Some patients have the rebound, right? And after the antiviral. So again, need to talk to your doctor. It's hard to say, provide a response that's going to fit everybody. But yeah, talk to your doctor. There are a number of different options, but not treating is one option, and obviously pursuing treatment, there's another one.
That's a great segue to our last question, Dr. Castillo. Many people put in the chat personal questions about their own medical situations, and I just want to really plug and invite everybody to get a second opinion, go for a consult, check out the IWMF physician directory so that you can be in touch with WM experts across the world, because that's going to be the best place to find your own medical, personal answers. But I have one last question for you today, Dr.
Sure.
Castillo. Before we wrap up here, what is the one thing you wish every WMer knew today? Is there anything you can leave us with as we close out this program in a moment?
Yeah, I mean, I think an important message for everybody here is that you don't have to be alone for this. There is a lot of people working on developing new treatments, developing new ways to diagnose this disease. There's a lot of support groups. I think the foundation is providing amazing resources in terms of education to patients and in terms of research funds from the laboratory perspective and the clinical perspective. So involve your family, involve your friends, learn more about your disease. I think if there are some things you cannot control, like how the disease is going to do or not do, there are some things that you can control is how much you know about this, how to look for help, where to look for help, so I think surrounding yourself with people that is, that's going to help you. And I'm talking about not only family members, but also, your medical team. You need to find a doctor that works with you and a doctor that listens, that hears what you're trying to say and doesn't dismiss what you're trying to say. I think it's an important thing. So yeah, don't be alone.
That is so beautiful. Dr. Castillo, thank you for the gift of your warm presence and wise words today. You offered us a lot of hope, which really is the most precious gift of all. We can't thank you enough. You're a true WM hero, and we're grateful for all that you do on our behalf to improve the lives of all of us living with WM. Mil gracias. Well, friends, yes, everybody give a wave and a shout and a little
thank you everybody. It's always so nice and a pleasure. I've seen so many familiar faces. I was scrolling the screen, so many familiar faces. So nice to see you all. You know who you are. So I hope to see you at some point shortly.
Dr. Castillo, there's so much love for you in the chat, so we'll have to somehow get you all those amazing messages.
Well, I cannot read 125 messages.
There's only 600 people. Well, friends, our hour together has flown by, but if you want to keep your connection to the IWMF going strong, please hop online, okay? Join the conversation with WMers around the world. We've got IWMF Connect, our online community, and our private Facebook group. You can check out a support group meeting. You can reach another WMer who is a lifeline volunteer by picking up the phone or just shooting an email. You can watch a past EdForm video, find a WM physician expert near you, or read the Torch magazine. And all this and more can be found easily and on demand from the comfort of your couch at iwmf.com. You don't even have to go anywhere. But remember, the IWMF EdForum will be held April 21st through 23rd, 2023 in St. Louis. It's going to be a hybrid model. So we're going to be offering an in-person experience as well as a virtual experience, the best of both worlds. Stay tuned, please, for registration information that will be coming to your inbox soon. We also have specialty support groups because we've got something for everyone at the IWMF. So if you're a young WMer, if you are a veteran, if you're a WM person of color, if you have extramedullary disease or you're a caregiver, join the conversation today. We've got a group for you. I want to once again thank Selectar Biosciences, our generous sponsor for today's program, and much gratitude to our fearless IWMF leadership. Pete DeNardis, the board chair, Newton Guerin, president and CEO, all of our board members, and our invaluable volunteer leaders. And last but not least, our IWMF dream team at the Sarasota office. We really love you guys. Most importantly, the IWMF is extremely grateful to each and every one of you. Thank you for being a part of our international family. We hope you enjoyed today's educational webinar. Please complete the quick survey, which if you will look down in the chat, you'll see the link is going to be there. And you can complete the survey to let us know how we did today so that we can keep improving and meeting your needs tomorrow. That's our goal. So remember, with the IWMF, as Dr. Castillo said, you are never alone. Dr. Castillo, thank you from the bottom of our hearts. Bye for now, folks. See you next time.
Bye now.